Hi guys, welcome to the next video, that is gynecological examination. So in prior video I have taught you about how to take a gynecological history. Now we will proceed to gynecological examination. So welcome to my channel Dr. Z, the AIIMSified WombWhisper. So how will we proceed here? First I will tell you the general format like I have told in Obs examination, in which point you should be taking the examination, and then I will tell you about how to do abdominal, local and pelvic examination in details in gynecological patient, and some questions related to practical exam. So when you are presenting a case, suppose a gynae case, so the examiner may ask you questions in between while you are presenting itself, and you should know the basics. It is expected from you to know the basics so that examiner can proceed to other theory question. But if you are not able to tell these practical questions, unlikely they will ask you any further question. So you should be knowing this, and these are the basics for us as a student and as a doctor. And then at last I will tell you about the format in which you will present a normal case, like if there is no significant findings, so how will you present a normal case, I will tell you that. Again, as in Obs, in gynae also we begin with general physical examination as in all medicine surgery, similarly in gynae. So you check the patient if she is alert, conscious and cooperative, oriented to time, place and person, if she is sitting comfortably at rest. So this one is new, ECOG PS. I'll tell you afterwards. So it is the performance status of the patient. We tell this point in suspected malignancy cases. Like if you are suspecting a case of malignancy, so you mention this point. Then you tell about the general condition of the patient, build, nutrition, hydration, vitals, anthropometry. Here the weight is present weight. I think you must remember in Obs I told you in Obs cases you will take the pre-pregnancy weight. Okay. Again, then you do head to toe examination. You check for pallor, icterus, cyanosis, clubbing, lymphadenopathy and pedal edema. Then you look for skin, hair, nails, skull, spine, gait, and you then see the orodental hygiene, neck veins, neck glands, and then bilateral wrist examination. Then comes systemic examination, CVS, RS and CNS, and after that comes the per abdomen examination, which you should be knowing in details, both all the inspection, palpation, percussion and auscultation. Then comes local examination per speculum, bimanual, which is also known as PV examination, and then comes rectovaginal examination. Not done in all cases, but whenever needed we do it to get some information about the case. So I will tell you afterwards where you do this examination. And then again similarly as in Obs, you present here the summary, then you present the provisional diagnosis, and here in gynae you present the differential diagnosis. So you present 4 to 5 DDs, and then from there, from the history examination, you make out the points why this DD is in favor of your provisional diagnosis and why not. So let's begin. I have told you about the nutrition, hydration, how do you assess pedal edema and all that in previous video. So here I'll tell you the specific points. So what is ECOG PS? ECOG is Eastern Cooperative Oncology Group. So from the name itself you can know that we do it in onco patient, like in cases of malignancy. And PS is performance status. So what is the performance status of the patient? If patient's performance status is not good, then it is unlikely she will tolerate the surgery. In gynae examination the surgery is vast, extensive, so the morbidity increases if the performance status of the patient is not good. So we need to do this for to know if a patient is fit for surgery, and also to prognosticate the patient. It ranges from score 0, 1, 2, 3 and 4. So what is 0? Patient is fully active. Like earlier before disease state, the patient was able to carry all her performance, and now also after she has been diagnosed with this condition or she has some chief complaints, after that also she is able to carry out her full performance without any restriction. What is score 1? When there is restricted physical activity, strenuous activity, but she is able to ambulate and carry out light work or sedentary work like light household work or office work. Score 2 is patient is ambulatory and capable of self care. She is capable of all her self care but not able to carry out any work activities, and she is up and about more than 50% of waking hours. And so in between 2 and 3, how do you make the difference? In 3, patient is capable of only limited self care. In 2, all the self care. And in 3, patient is confined to bed and chair for more than 50% of her time. Here she was up and about in more than 50% of the time. And in score 4, patient is completely disabled, she cannot carry her self care. So in these category of patients 3 and 4, we generally don't operate because patient may not be able to tolerate the surgery, and then the post-op complications may be more in this type of patient. So you need to mention this point in cases of malignant cases, and there may be question that what is ECOG PS and what are the scoring and what is the significance of this score. Now some preliminaries before abdominal examination. As in always, you take the consent of the patient, you tell the patient to empty her bladder. In case of male doctor, you need a female attendant. And then you stand on the right side of the patient, you explain the patient what you are going to do before each step, and the position of the patient is dorsal or supine position with knees flexed, and you tell the patient to relax her abdomen so as to facilitate your examination. Okay, and expose only abdomen, you don't need to expose from nipple to mid thigh, that's not needed. You just expose from xiphisternum to pubic symphysis or more when it is needed. So you maintain the dignity and privacy by examining in a closed room or in presence of the screen guards. So first is inspection of abdomen. In per abdomen examination, first thing is inspection as always. So what do you look for in inspection of the examination? You look for the shape of the abdomen. Is it flat, scaphoid or distended? You look if the umbilicus is central, inverted or not, inverted, everted or flat. You look if all the quadrants of the abdomen are moving with respiration, if there is any sinus, scar, fistula or any dilated veins, if the hernial orifices are intact or not. I have told you how to look for the hernia, like the knees are flexed and you look at the inguinal region and you tell the patient to turn her face to one side and cuff, and you look for any cuff impulse on that inguinal region. And then you check for if there is any signs of intra-abdominal mass or organomegaly or distension. How will you know? There will be fullness, there may be local fullness on one side of the abdomen, so that may indicate some mass or distension, whatever. And now palpation. Palpation is superficial palpation and deep palpation. In superficial palpation, you look for temperature. So with the back of your hand, you check temperature in all the quadrants in clockwise manner. Then you check for guarding, tenderness and rigidity. So while checking tenderness, you need to talk to the patient, you need to divert her mind so that there is no false wincing on superficial palpation. So you need to divert the mind of the patient while checking for tenderness. And then you check for guarding. So what is guarding? When you try to palpate, patient will tighten her abdomen, and rigidity also. And then comes deep palpation, where you will palpate all the quadrant, okay, in clockwise and systemic manner. So what will you palpate? You will check for any mass. If mass is present, then you check for the firmness or the softness of the mass, irregularity, and you check if there is any distension or not. If you think that this area is tender on palpation, so what do? You check that area at last, because if you do it on first, then patient may become uncomfortable and she may not allow you to check the other areas. So you check that areas at last. And also check for rebound tenderness, because what is rebound tenderness? So when you just palpate and when you lift your palm, patient will wince with pain. So that is rebound tenderness, not on palpation but on releasing your palm from the abdomen. and this is a sign of peritoneal irritation. So this is a question, what does rebound tenderness tell you? In where we find it in surgery, in surgical patient we find it in intestinal perforation or obstruction. And if any mass is there, how do you define the mass? So you define it with site, which region or which quadrant, hypogastrium, epigastrium, iliac, right or left, you define the site of the mass. Then in size, in approximate dimension, either corresponding to Itnavik's gestation or corresponding to this much centimeter approximately. Then you tell about the shape of the mass, if it is round, oval, irregular, the surface is smooth or nodular. When you palpate it, you will know the borders, if you are able to palpate all the borders or not. So here is one question, if you are not able to palpate the lower border, the lower extent of the mass, then what does it tell you? It tells you that the mass is of pelvic origin, because the mass is coming from the pelvis to the abdomen, that is why not able to palpate the lower border. So this is one of the question. You check for the consistency of the mass, if it is soft or firm or hard or cystic, and mobility, horizontal and vertical mobility, if it allows to, obviously if the mass is so large then you won't be able to do so. And you see if the mass moves with respiration. So what does it tell you? If a mass moves with respiration, then either it is originating from liver or spleen, whatever, so which is near the diaphragm. But if a mass is not moving with respiration, then it is it may be pelvic organ mass or retroperitoneal mass. You check for tenderness, if there is any tenderness on palpation, and other signs you look for any fluctuation or ascites. So how do you, here I have given one example. If you palpate a mass, how do you define it? So you define it as, on palpation of the abdomen, there is a firm, well defined ovoid mass of approximately this much centimeter arising from the pelvis, occupying the hypogastrium and extending up to 4 centimeter above the umbilicus. The mass is non-tender, mobile, with smooth surface and well defined margin, and lower margin is not filled, and the mass does not move with respiration. So this is how you define the mass on palpation. Percussion is when you find any ascites. So you check, if no ascites, then you check if there is resonant, tympanic and dull note. So this is one question, where do you find resonant note, where do you find tympanic, and where do you find dull note? Where it is resonant, now this is the question, you tell me where is it resonant, and you you tell me in the comment section. And you check for shifting dullness, if there is any you feel like there is any ascites, so that confirms free fluid in the abdomen. There may be one question, that what is puddle sign? So if there is small amount of ascites, neither you can do percussion or you can elicit shifting dullness. In that case, you can elicit puddle sign. You place the patient on her knees and elbows, and then the fluid may collect. It will come down and settle in the near the umbilicus region in the abdomen, and then you can do percussion and elicit presence of ascites. And then you do auscultation for bowel sound. So now comes female pelvic examination. So what are the prerequisites for pelvic examination? Again, same. You tell the patient to empty bladder. Patient is placed in dorsolithotomy position. It will be better if you have any lithotomy table or examination table. You explain the patient what you are going to do, and then you glove your hand, and you need good light for pelvic examination, and you stand on the leg end side of the patient when the patient is in lithotomy position, dorsolithotomy position. So first you do local examination. Okay, so in local examination you do inspection of external genitalia. So what does external genitalia consist of? You look at the mons pubis, labia majora, minora, you look at the perineum and the anal region, and you look if there is any swelling or any lesion or any irregularities in the region. If not, then you can just say that external genitalia appears normal. Then you separate the labia. You just do your hand like this. You separate the labia and then you check labia minora, clitoris, urethral opening, introitus and perineal body and anus. And again look for any tenderness or pigmentation or erythema or vulvodynia. So vulvodynia is burning pain in the vulva. If you found any lesion, then you check for the mobility, consistency and tenderness of the lesion and the approximate size of the lesion, size and location also. And it's better if you draw like where is the lesion. Okay, so you can draw locally, like this is labia majora, this is minora, this is urethral opening and this is vaginal opening and this is anus. So if it is right and this is left, you can draw like this. There is some approximately 2 into 1 centimeter swelling in right labia majora in inferior aspect, inferiorly. So it's always better if you can draw locally. You don't need to be a very good painter or drawing master. You just draw it. It better explains than writing. And if there is any lesion, any any bad looking growth, you always take biopsy. Then comes per speculum examination. So what are the key steps in speculum examination? You use the smallest width speculum, whatever available. Like if a patient is nullipara, so you may need small speculum. You cannot use a large speculum in that case, as it will be very uncomfortable and painful for the patient. But like in multiparous patient or 40-50 years who had the 4-5 vaginal births, you can use large speculum, because if you use smaller speculum, you cannot just separate the vaginal walls itself. So use the speculum accordingly and you lubricate the speculum. You can use warm water and lignocaine jelly also, but remember, if you want to take pap smear, you cannot put lubricant, otherwise the reports may be false, maybe falsified. So in that case you use warm water or just a very little lubricant, otherwise you can lubricate it very well. How do you insert the speculum? Similarly, you just separate the labia, then you hold the speculum vertically and closed. The blades of the speculum should be closed. I am talking about cuscous speculum. Okay. So the blade should be closed and oblique or vertical, and then you separate the labia and then you advance through the posterior vaginal wall, insert in the introitus, and once it is inserted fully, you rotate the blades horizontally and then gently open and then fix up the screw. You fix up the screw in such a way that cervix is fully visible, so as to facilitate your examination and also facilitates your pap smear taking. So you fully expose the cervix and then you rotate slightly here and there to look for the other vaginal walls and cervical surfaces. You take the pap smear. If there is any lesion in the cervix, you take the biopsy, and if there is any discharge, you take the high vaginal swab or in swab for any purulent discharge. Okay, so after taking pap smear and vaginal swab, if needed, you do inspection of the vagina and the cervix. In inspection of the vagina, you look at the vaginal wall, you look at the vaginal mucosa for rugosities. Normally in postmenopausal patient, rugosities are lost. So if you are examining a postmenopausal patient, like in postmenopausal bleeding or postmenopausal, any mass abdomen or adnexal mass, you must comment on the rugosity of the vagina in local examination. You look for if there is any local swelling or not, and if there are like many patient comes with with no menses till 18 years, 19 years, or with cyclical abdominal pain. In that case, there may be imperforate hymen, or there may be transverse vaginal septum, or there may be any other septum in the vagina. So you look for that also in that cases. Normally in unmarried patient or in patient who in teenage girls or in childs, we don't do per speculum examination, we do per rectal, that I'll come later. Then in the cervix, you look for the size and the shape of the cervix. Normally the nulliparous cervix is small and the os is pinpoint, while in multiparous the cervix may be bulky and there is slit like os. So you look for the shape and size of the cervix, you look for the cervical surface, if there is any erosion, there is any erythema, there polyp, any growth, and if there is any bleeding or not. Okay, so you do inspection of the vagina and the cervix. Then comes, after per speculum examination, bimanual examination, that is PV examination. So this image I have taken from Novak's Gynecology. This is one of the standard books for gynecology. This is one question: how do you do bimanual examination? In most of the time, students don't know how to do bimanual examination. Where do you place your finger, in the posterior or the anterior fornix? Where do you place your, the left hand in the abdomen? Bimanual, because you are using both your hands. So here you can see, the finger is placed in the posterior fornix so as to lift the lower portion of the uterus, and then you place your hand above the fundus, above the suprapubic region. So the uterus comes in between your hand and you can palpate the size of the uterus, the direction of the uterus. Okay, so remember, it is posterior fornix, not anterior, during bimanual examination. So similarly, you glove your hand, you lubricate with lignocaine jelly, and then you insert 1 or 2 finger accordingly, and from the abdomen counterpart you provide pressure, counter pressure, and then do palpation. So what will you palpate in bimanual examination? First you will encounter cervix, then you can palpate uterus, you can palpate lateral fornices and all the other fornices, lateral fornices, anterior and posterior fornices. Okay, so and in the fornices, what will you look for? You look for any adnexal mass or not. So you look for any mass or irregularity, you look for the position of the cervix. If the uterus is anteverted, where will be the cervix? Yeah, tell me. So cervix will be posterior. If the uterus is retroverted, cervix will be anterior. So these are the minor questions asked in practical examination, and you should be knowing this. Okay. You assess for the size and shape of the uterus, the mobility of the uterus in case of any uterine mass. You look for the irregularities, the contour of the uterus may be lost, it may be irregular. You look for the consistency of the mass. If it is fibroid, it will be firm to hard. If there is fibroid degeneration, it may be soft also. So look for the size, shape, location. Similarly, as I explained in abdominal examination, all those points of the mass. In adnexal, in normal cases, ovary is not palpable, but if you are able to palpate something on your lateral fornices, it means there is something abnormal, the mass is not normal. Okay, so you also palpate for in both sides for any enlargement, and if any mass is present, similarly look for the size, surface, mobility, tenderness, all those. And how do you look for tenderness? Obviously you look at the facial expression of the patient. Similarly, if any mass is palpable on bimanual examination, you tell about the site, where from the site you can differentiate if a mass is originating from the uterus or the adnexa. What adnexa is consist of? Ovary and tube. So how will you differentiate? If you are able to palpate uterus separately from the mass, then the mass can be either of adnexal origin most likely, or it can be subserosal fibroid. But if you are not able to palpate the uterus separately, then likely the mass is of uterine origin. Okay, you then tell the size in approximate centimeter or period of gestation, and you tell about the shape, surface, border, margin, consistency, mobility, tenderness, and additional. These are the additional findings which can be there. Mass can be bilateral, adnexal mass can be bilateral. You look for any pulsation, any fluctuation, ascites, and any whatever cervical or any adnexal finding is there, you just note it down. So how do you describe a bimanual examination? So you describe as on bimanual examination a firm, smooth and well-defined mass of this much centimeter is felt in the left adnexal region separate from the uterus, which is mobile, non-tender and suggestive of adnexal mass. Now comes rectovaginal examination. Similarly, you place your index finger in the vagina and your this finger in the rectum, and again you provide counter pressure from the abdomen with your other hand, and in between this two finger you palpate the, what do you call it, parametrium. Okay, the rectovaginal septum, and laterally you feel for the parametrium. What will you look? So first thing is rectovaginal examination do you do it in every cases? No, you don't do it in every cases, as it is very much uncomfortable and not needed in all the cases. So when do you do it? You do it to in case of endometriosis, in case of malignancy, to look for the parametrium, to look for the rectal mucosa, to look for the rectovaginal septum if it is involved in cases of malignancy or not. In endometriosis you may find nodularity, so that is suggestive of endometrial implant. So in cases where you are getting information by doing the examination, then only you do it, otherwise you don't. So in rectovaginal examination, you evaluate rectovaginal septum, posterior uterine surface, adnexa, uterosacral ligament, and posterior cul-de-sacs, POD. So if there is uterosacral nodularity and tenderness, this is suggestive of endometriosis. If there is any mass or any nodularity in the parametrium, it is suggestive of some cancer implant, most likely ovarian, it can be cervical, uterine and others also. So how do you do it? You place your finger like this, then you just swipe to one side and then you swipe to other side, and between this finger you feel for any nodularity or any fibrosis like thing. For MBBS student it is not needed, but for junior residents you need to do it. If you are given a case of malignancy, you have to comment on rectovaginal examination. So you do it like this and you feel for the parametrium. If you see if it is shortened or it is fibrosed or you are feeling any nodularity. Similarly, when your one finger is in the rectum, you just palpate the rectal mucosa, you see if it is involved in case you feel any growth or any nodularity in the rectal mucosa also. So you do it like that. And in cases with intact hymen, like in teenage patient or unmarried girls or in child, you do recto-abdominal examination. You don't do PV examination. So you put one hand on the abdomen, your left hand in the abdomen, and then one finger in the rectum, and you from the anterior rectal wall you assess for cervix, any uterine or adnexal mass, and from the other rectal walls also you check for any abnormality present or not. So after the examination you inform the patient if you have found any abnormal things. If examination is normal, you reassure the patient. If you have found any abnormality, you tell the patient what you are going to do next. If you are going to do examination, what will you do when you will call the patient. So you tell the patient in details. Now comes the final format. If the examination findings are normal, how do you write the case? So you write like this, all these things I have told. ECOG P is 0, like patient is fully active, no change in pre-disease or post-disease status of the patient. All these vitals, anthropometry, head to toe examination, systemic examination. In per abdomen examination, you write all this separately: inspection, palpation, percussion and auscultation. Inspection: abdomen is scaphoid, umbilicus is central and inverted, all quadrants moving with respiration, no scar, sinus, fistula, hernial orifices are intact. On palpation, local temperature is not raised, no guarding tenderness, rigidity. On deep palpation, no hepatosplenomegaly. In most of the cases, patient writes, or many of the student writes organomegaly. So one of my teacher told me that you should not write organomegaly because you cannot palpate all the organ. You cannot palpate stomach, you cannot palpate bowel or whatsoever. You can only palpate liver and spleen. So better you mention it hepatosplenomegaly. and if any mass is palpable or not. If not, then no mass is palpable. There is no inguinal lymph node palpable also. On percussion, tympanic note is present. On auscultation, normal bowel sound is heard. In local examination, external genitalia appears normal. On per speculum examination, cervix and vagina is healthy. There is no vaginal discharge and pap smear is taken. So in one of the upcoming classes, I will tell you about pap smear, when to take pap smear and details regarding that. So you should know if you are mentioning pap smear, in which patient you should mention it. On bimanual examination, which is also known as per vaginal examination, cervix is firm, posterior and regular. Uterus is anteverted. See, uterus anteverted, so cervix is posterior. Normal size, firm, mobile and non-tender. Bilateral fornices are free and non-tender. On rectovaginal examination, rectal mucosa is free and no nodularity is felt. Okay, and then you tell about the summary. In summary, you tell the history, the important positive findings and the important examination findings. Then you give a provisional diagnosis and then 4 to 5 differential diagnosis and explain what points are in favor of this differential diagnosis and what points are not. So thank you guys for listening to my video. I hope it benefits you in some way or other, and please subscribe to the channel for further videos. See, I put in a lot of efforts. I have to read standard books again, so it is benefiting me also. I am forgetting things much later than what expected. So if you teach also to your colleagues, your junior, you will also retain it for longer. So it's benefiting me as well as you. So please subscribe the channel, like the video, and you can ask any question, any of your doubts. See, I may be wrong in when I am explaining. It may just come in flow, something which is not right or whatsoever. So you can tell me in the comment, and if in case you have any doubt, you can ask me in the comment section. Okay, so thank you and subscribe for more videos. Thank you.